One. And we're rolling. Hello, everyone. Welcome to the NACFC Highlights 2023. My name is Nicole Kohr. I am a 30-year-old cystic fibrosis patient. I am a bilateral lung transplant recipient. I am a biracial nonsense mutations with diabetes and gastroparesis, and I'm all the things representing all of the groups today. And I am so excited to be moderating and to be in touch with all of you. If you are someone who follows me on social media, you'll know that I've been posting about the NACFC and this particular highlights webinar for a while now. In the past, a lot of these conferences that were clinically based or science and data driven, that's wonderful, right? That's how we are going to make CF stand for cure found. However, as a patient who lives with it every day, I wasn't necessarily their target audience early on, right? It was a bit overwhelming with information, but this year in particular, between ResearchCon and NACFC, I have found these conferences to be therapeutic, validating, and inspiring. For example, there were questions that I had when I would go into these conferences. I would say, why does my lung function tank when I'm hormonal? That's never really something that's been addressed at clinic when you're on full nighttime oxygen and you're fainting on the floor due to your diabetes, priorities. Or I'll ask, what if I qualify for modulators, but I can't tolerate them because of mental health, anxiety, depression? If I were not producing as much phlegm, how can we detect infection and treat it properly without breeding resistance? All of these questions and more were answered at the NACFC. So our job today is to take all of that overwhelming information and compress it into the validating and inspiring bits that I need, that you need, that we need, again, to make CF stand for cure found. So with that being said, we have a few housekeeping items. Can we get those up on the screen, please? We are going to start with some logistics. So this event is being recorded and will be posted on YouTube. Everyone watching tonight will receive an email with a link to that recording. So if there are any last minute registrations out there, or you can't stay the whole time, you will get this video link in your email. So no worries. To turn on the live Spanish translation, this is cool. Click on the interpretation button in the Zoom menu. So down below, you should see a little icon. I believe it's maybe like a globe. At the bottom of certain slides, you will see references to NACFC presentations where you can learn more about the topic being presented. So for example, if we're giving you a snapshot of genetic therapies, but you want to learn more, you can click on that and find the whole world of more information. We'll have time at the end to take your questions live. So please type your questions at any time into the Q&A box. I will go through as many as I can at the end with our brilliant doctors. Unfortunately, we will not be able to take questions in Spanish during the webinar, but if you email them to research@cff.org, we can send you a response in Spanish. Can we just put that in the chat, please? Just so everyone has that. If you use the event chat, you can change it to all panelists and attendees. That way we can all see it, just like Jen did. Thank you for being the first to type, Jen. And the default is panelist only. So just make sure that we want to make sure everyone can see what you're communicating. Now, let's briefly discuss the agenda of this webinar. Our first presenter will cover the latest updates on modulators, genetic therapies, infections, and sexual and reproductive health. Our second presenter will discuss highlights from research into mental health, cannabis use, sleep, health equity, and transplant care. Then we will answer questions from our audience like we already discussed. So time to introduce our first presenter, Dr. Traci Kazmerski. Dr. Kazmerski is a pediatric pulmonologist and health services researcher at UPMC Children's Hospital of Pittsburgh. She is an assistant professor at the University of Pittsburgh School of Medicine in the Department of Pediatrics and Division of Adolescent and Young Adult Medicine. Whew, busy lady. Her current research projects focus on improving the sexual and reproductive health care of people with cystic fibrosis. Hello, doctor. How are you doing?
Thanks, Nicole. Hi, everybody. Let me just share my screen up today. And it really starts with this genetic defect, which leads to an abnormal CFTR protein and this dysfunctional or missing chloride channel. And without that channel, there's this vicious cycle within the lungs of infection, inflammation, and mucus buildup that happens and leads to advanced disease. So when we're thinking about therapies for CF, we can imagine breaking into this pathway at several points. So if you want to go to the next slide. So the first is to fix that abnormal CFTR protein and restore functioning chloride channels via CF modulators. So I want to start with an update from NACFC on modulator therapy. Next slide. So as many of you may know, modulator therapy is currently approved for about 94% of those with CF in the US. And if you click forward, what we know is that 94 is not 100%. So it's essential for us to provide additional options for those who are not eligible for modulators. Importantly, those who can't tolerate modulators, and those who only experience a modest clinical effect. And I want to highlight that Anna's going to address more about those who can't tolerate modulators, including mental health side effects, later in this presentation. And I also want to highlight that this disproportionately impacts some folks, as 30% of those who are ineligible for current modulators identify as Black, Indigenous people of color. So next slide. So first, I want to talk about expanding access to highly effective modulator therapy for more mutations. And the first study I want to highlight is a trial of elexacaftor, tezacaftor, ivacaftor, or Trikafta, or ETI in these slides, for those with an N1303K mutation. So what is N1303K? And similar to Delta F508, this is a class 2 folding mutation. And people with this mutation are currently not eligible for ETI. So let's go to the next slide. So in this study, Dr. Solomon and colleagues from UAB conducted a prospective 2-center open label trial where they enrolled 20 people with CF who had this mutation and another minimal functional mutation that were not currently eligible for ETI. They enrolled people ages 12 and up, and they had them on ETI for 28 days and then off for 28-day washout period. So they served as their own controls. If you can click to the next bit. And what they really thought that was ETI was going to restore sufficient CFTR function in these folks, decrease their sweat chloride, and improve key clinical outcomes after 28 days. So what did they find? So among the 20 subjects, they did not see a change in absolute sweat chloride, but they saw a remarkable and significant improvement in lung function, quality of life, and weight. And why is this important? So this type of trial blends rigor with feasibility for testing a drug like this in people with rare variants. This is also a model for research referrals, as a lot of the participants traveled from their home center to UAB to do this trial. The results from this trial importantly led to the majority of participants gaining access to this drug, as well as reimbursement by payers in the United States. So the second study I want to highlight is assessing how standard therapies work alongside current modulators. So the simplified trial studied whether stopping hypertonic saline or dornase alpha is safe for people with CF on ETI. And in the main study, over a 6-week period, they found stopping one of these medications did not result in any meaningful differences in lung function in participants with well-preserved lung function. In this sub-study, investigators assessed the impact on mucociliary clearance, or the ability to move mucus from the lungs. And if you click, this is really getting into this vicious cycle of mucus buildup, infection, and inflammation that happens in CF. So why is a study like this important? So mucociliary clearance directly reflects how both hypertonic saline, dornase alpha, and ETI work. And if this becomes abnormal when stopping either of these drugs, that could be a red flag for longer-term badness. So what did they find in this study? So there were 34 people in this sub-study. And first, I'm going to show you data on what happens to folks who stopped hypertonic saline. So there's 3 graphs here, and in each of these graphs, the measure of mucociliary clearance is on the y-axis, or the up and down part of the graph. And the 2 groups, those who discontinued and those who continued hypertonic saline, are on the x-axis, or along the bottom of the graph. And the results showed that there is no difference in mucociliary clearance between groups who continued or discontinued hypertonic saline. So if we go to the next slide, what about dornase alpha? What happens if you stop this? And now you'll see that folks who stopped dornase alpha had significantly improved mucociliary clearance. In the second panel on this figure, you'll see it was by an average of about 6%, which is a clinically meaningful change. And what does this tell us? So stopping hypertonic saline or dornase alpha while on ETI does not result in worsened mucociliary clearance over 6 weeks in people with CF with preserved lung function. And furthermore, there was a significant improvement of mucociliary clearance in those who stopped dornase alpha. So really what's needed is a bigger study with more than 34 people, and also including people with worse lung function and following them for a longer period of time. In the meantime, as a pulmonologist, I may look at these results and consider advising to stop dornase alpha rather than hypertonic saline in people with CF who have preserved lung function on ETI. And I think the most important thing about this study is that it's a really important idea. We need to retest our standard therapies in people who start highly effective modulators. All right. So going back to this roadmap, I want to give an update on genetic therapies. So genetic-based therapies are strategies that will allow us to achieve CFTR restoration for all people with CF, regardless of mutation, and eventually a one-time cure. So just to review what we mean when we say genetic therapies, imagine CFTR as a car. The car is the CFTR protein, and the car problems are CFTR mutations. So going one step further with this analogy, you can split genetic therapies into 2 general groups, gene addition and gene editing. So in gene addition, researchers are exploring strategies to deliver correct copy of either messenger RNA, mRNA, or DNA to cells. By providing the correct genetic instructions, cells are then reprogrammed to make functional CFTR protein. Both approaches, mRNA therapy and gene therapy, restore CFTR protein irrespective of mutation, and both will require redosing. But in both approaches, you get a different car. On this figure here, either a rental car or a new one. Now in gene editing, which is the last panel on this figure, you are repairing the car. So editing enzymes target, cut, and permanently repair the CFTR gene. So next slide. In plenary 1, Dr. Thompson, an internationally recognized physician scientist in sickle cell disease, highlighted that there is emerging application of gene therapy for many conditions, and most of these are in the early stages, meaning preclinical trials or phase 1 or safety trials. This graph here shows the current landscape, and I encourage you to think of this like a bullseye. So things on the periphery here are drugs or therapies that are in the early stages, but things in the center or the bullseye are marketed and in use by patients. And our goal is really to get to the center of the bullseye for all people with CF. Dr. Thompson showed incredible data on gene addition and gene editing strategies for people with sickle cell disease during plenary 1, which I encourage you to watch. And then Dr. McCrae highlighted in Plenary 1 how we can harness cross-disease knowledge for gene therapy for people with CF. He looked at this with both via gene addition and gene editing strategies. If you click, he showed that gene addition using a lentivirus vector can restore CFTR function in the CF pig model, and that correction persists over time, and that a clinical trial is planned for 2024. He also showed that the ongoing 4-DMT gene addition trial he showed some preliminary results of that work, and that trial is still ongoing. If you click again, he also highlighted that peptide-delivered base editing corrects class 1 mutations or stop mutations and restores CFTR function in human airway cells. So those results must be further analyzed and then translated into human trials. If you click one more time, in another symposium, the Arcturus lunar CF gene addition therapy uses something called lipid nanoparticles that are aerosolized into the lungs. They found that delivering genes in this way was effective in the CF ferret animal model, and they are currently testing it for safety in human subjects in a phase 1 study. So more to come. If you go to the next slide, I want to highlight in one of the symposiums, we heard from the founder and chief scientific officer of SplySense, Dr. Bathsheba Karem. And I want to start by saying, human genes are made up of coding parts, which are exons, and non-coding parts, which are introns. And this act of splicing removes introns. And then the exons are joined together and they generate mRNA, which inevitably gives the instructions to build protein. So what happens when splicing goes wrong? And if you click, indeed, that's what happens in class 5 mutations. And these are splicing mutations which impact about 4,000 folks with CF in the US and Europe. Dr. Karem showed data describing antisense oligonucleotides, or ASOs. And these are single-stranded RNA-like short sequences that can fix splicing. In addition, she shared that SplySense is conducting a clinical trial of one of these therapies in people with CF with a class 5 splicing mutation. And then really excitingly, she shared that they are testing ASOs among people with class 1 mutations as well. So I think there's more to hear from this exciting technology, and we should all stay tuned. All right, I want to turn again to the map and focus on updates on treatment of infections for those with CF. So in Plenary 2, Drs. Natalie West and Luke Hoffman provided an update on this, and they highlighted that the prevalence of CF infections has changed over the past 20 years. And this was really influenced, as you can see on the figure, by the pandemic and the uptake of highly effective modulators. If you click, they highlighted that infections and treatment are high priorities for people with CF. And this was shown in a study from the James Lind Alliance just this past year. Now, a big problem, and I say problem in quotes, is that infection care was largely based on testing sputum that people produce to see what bugs they're growing and what they're sensitive to for antibiotic therapy. But people with CF aren't producing sputum as much anymore. So Dr. Hoffman highlighted research into sputum collection at home, into sputum induction techniques, into the development of breath biomarkers to test for bugs that may exist in the lungs, and finally, in the use of cell-free DNA, which detects markers of CF bugs in the blood. In the next slide, Dr. West went on to describe the ongoing work of the STOP program, which seeks to better understand the length, location, and the components for treatments for pulmonary exacerbations. She shared the published results of the STOP observational and STOP2 trials in the plenary, and then she highlighted that next steps in the program were guided by community engagement. And she went on to describe the STOP 360 program. And this is really a platform and a study design that's hopefully designed as a protocol that can ask many questions and can be used for multiple clinical trials. Now, the first of which is how many antibiotics are really needed to treat a Pseudomonas infection during a pulmonary exacerbation. So this STOP 360 trial is currently enrolling. Finally, she described future studies that are going to look at whether at-home versus hospital versus IV antibiotics are preferable and better for treating pulmonary exacerbations in people with CF. And last but not least, she highlighted the STOP PEDS pilot trial. And this really examined if we could actually avoid antibiotics and instead pursue watchful waiting in many pediatric cases of kids with CF who are getting sick. And this pilot trial showed that this type of study is feasible and a larger study is in the works. And then I would just want to switch gears for the end here and highlight, again, we talked a lot about the lungs, but CF really impacts the whole body. I don't have time to highlight advancements in everything tonight, and we'll be putting some recommendations in the chat for some of the other organ systems on this figure. But I did want to spend some time focused on research related to sexual and reproductive health. Now, there were 4 sessions at NACFC focused on sexual and reproductive health, and I'm going to highlight results from a few here. So the first session I want to talk about was called Boys to Men, and it focused on a variety of male sexual and reproductive health concerns in the modern era of CF care. And there's a couple highlights I want to share. The first is that hypogonadism or low testosterone is known to impact some males with CF, but how many people this affects is really unknown. Data was shared from a single center study of about 129 males with CF, and it showed that 42% did not ever have a testosterone measured, but among the 67 who did, 1 out of 5 had clinically low testosterone. So more multi-center work is really needed to better understand the prevalence of low testosterone in CF. The second talk of this session really focused on the fact that studies in cancer registries have demonstrated a higher prevalence of testicular cancer in the CF population. There's a need for much more research in this area, but several cases were presented, and the need for self-screening and education on this topic was emphasized. Next, Ms. Olivia Stransky presented data from an 8-center survey study of males with CF ages 15 years and older. So among the data of 365 participants thus far, it was shown that knowledge around sexual and reproductive health, including fertility, was suboptimal, and that access to sexual and reproductive health care services, especially around sexually transmitted testing and counseling, was really low. This is important because a large majority of males who were surveyed considered their CF provider to be their main health provider. And nearly half don't have a primary care provider outside of their CF team. Finally, the final 2 presentations in Boys to Men highlighted areas for future research, and Dr. Woods from the Ladoris lab at UAB shared formative research on a fertility preservation educational intervention. So speaking of research, I think that if you're interested in having your voice heard on this topic in particular, please scan this QR code or go to this website or access this through CF Foundation's Community Voice to connect to an ongoing research opportunity to shape the priorities for male sexual and reproductive health in CF. Now, with the increased uptake of highly effective modulators in the US, we've seen a baby boom among people with CF. So the Mayflower study team, led by Drs. Raksha Jain and Jen Taylor-Kauser, presented interim results examining the maternal and fetal outcomes in the era of CFTR modulators. Thus far, 206 participants over 41 US sites are enrolled and counting, and there have been 102 live births thus far. The majority of participants are continuing on CF modulators for all or part of their pregnancy. And it's really too early to draw conclusions yet, but there are some trends that they highlighted at the conference. So on the next slide, you'll see that lung function measured by FEV1 is maintained during pregnancy, but in the postpartum months, they were seeing some decreases. Next, weight increases appropriately during pregnancy and is maintained postpartum. And quality of life declined in the 3rd trimester of pregnancy. Depression and anxiety scores were low throughout. And then finally, premature births are higher and miscarriage rates are lower than the general US population. So as I said, these results are still ongoing, so stay tuned for more. In looking outside of pregnancy and into the parenting years, I highlighted the HOPE CF, or Health Outcomes of Parents with CF study, which started this year. So this is funded by both the NIH and the CF Foundation, and it seeks to determine the health impact of parenthood on people with CF in the era of CFTR modulators. So stay tuned for more information on that project and its results in future NACFCs. The second upcoming project that I would like to highlight is the PRIDE CF study. So this is funded by the CF Foundation, and its goal is to explore the interplay between having CF and identifying as a sexual or gender minority. Stay tuned for more information on this project because recruitment is not going to be attached to CF centers. Thus, you can be any LGBTQIA+ person with CF from anywhere in the United States and participate. If you're interested in shaping this work, click here or go to this website to receive more information, again, about an ongoing research opportunity to map what's really needed to improve the care of this population. And then finally, I want to highlight that was a quick update, and it took longer because I can't figure out technology. But I do want to say that many of these projects in sexual and reproductive health are led by members of the Sharing Working Group, which is generously sponsored by the CF Foundation. Importantly, this group has members who are people with CF and loved ones of those with CF, and they provide key perspectives and shape this work going forward. So the future of sexual and reproductive health research and CF is really bright. And I know that in years to come, there's going to be more to share. But for now, I'll stop sharing and turn things over to Anna. Thank you so much.
Nicole, I don't know if you have any words you'd like to say before I get started with my section, but if not, I will.
Absolutely. Can you hear me, Anna?
Yes.
Yeah, apologies.
Yeah,
apologies. I think my computer got excited with all of the boys to men dialogue, and then it just kind of died out from there. So jumping right back in, yes, I would like to introduce you, Anna, Dr. Georgiopoulos here, and she has another full plate. She is our second presenter. She is a consulting psychiatrist for the Massachusetts General Hospital CF Center and an associate professor of psychiatry at Harvard Medical School. She has played a key role in developing and implementing international guidelines for screening and treating depression and anxiety in people with CF and their caregivers, and the CF Foundation Palliative Care Guidelines. Welcome, Doctor.
Thank you so much. I am going to try to share my screen. Okay, hopefully this is working for everyone. So I thank you, Nicole, and thank you, Tracy, for taking us on that whirlwind tour of so much information. And it's really always so exciting to go to the NACFC meetings and see all the work that's being done. These are my disclosures. And this is an overview of the things I'd like to touch on tonight to talk about our mental health plenary, which was super exciting, CFTR modulators and mental health, some other mental health conditions like cognitive or thinking problems, attention problems, cannabis, sleep, and to then talk about lung transplant briefly and health equity. So as I said, one of the most exciting things for me, certainly this year, was the third plenary, which was devoted to mental health for the second time in the history of the North American CF Conference. And Dr. Beth Smith talked about care and all the progress we've made in integrating mental health into care teams. I talked about research and where we are and where we're going, including the formation of a group similar to what Traci described with the sharing group for sexual and reproductive health. We now have a group called PRIME, Prioritizing Research in Mental Health, that is going to be focusing on moving CF mental health research forward. Just like the Mental Health Advisory Committee is moving care forward and also collaborating with PRIME around research and supporting CF care teams. And then the third part of the plenary was Shayna Blair, a social worker at a CF center, talked about CF care team well-being, which is also a really important thing to focus on, because if we need to be able to sustain ourselves to be able to provide the best care to the CF community. So one of the things that I talked about at the third plenary is the fantastic pipeline of CF-specific interventions for depression and anxiety. So just like we have a pipeline of all of these other kinds of treatments for CF, we now have a pipeline of mental health interventions, again, specifically for depression and anxiety. And some of those relate to the health of adults. Some of them are aimed at young adults or teens or families, and then some are in a group format as well. And we don't have time to talk about all of these programs that are in the pipeline, but I did want to highlight a couple of them because there were two that presented really important results of randomized trials, so big clinical trials looking at how well did these programs work, and so these two programs I'm going to highlight. One is based on cognitive behavioral therapy, and the other is based on acceptance and commitment therapy. And these are both evidence-based treatments that have a huge amount of evidence behind them for effectiveness for treating and preventing depression and anxiety. But the difference with these interventions is they've been modified with the input of people with CF so that they are CF specific and relevant to the needs of the CF community. So this was CF-CBT is a project that I've been a part of, and Deborah Friedman presented this in the Psychosocial Research Showcase. So what we did was to randomize 60 people to either who had mild symptoms of depression and anxiety, but no symptoms that were more moderate or severe at that time. And they would either start CF-CBT treatment right away, or they would wait for 3 months and then start the treatment after that. And this was added to whatever usual care the CF Center would normally provide. And we saw that there was, we started to see improvement in depressive symptoms, and we did not see a difference in that time period in anxiety. And that's an interesting finding, and maybe because most of this was happening during the pandemic, so probably holding anxiety steady was not such a bad thing to be able to do. And also remember that these symptoms were starting at the mild level, so there wasn't much room to go down. There was plenty of room to go up, but we didn't see much worsening in symptoms. One of the really important findings, though, was about coping self-efficacy, which is the sense that you can do something to make things better for yourself, or to, that you have some control over situations. So there's a scale called the CF Coping Self-Efficacy Scale, which we developed for this trial. And we saw huge improvement in all 5 of the subscales for people who were able to add the CF-CBT treatment to their usual care. So relaxation skills, acceptance-based strategies, adaptive thinking, stress management, and coping with self-care. And this is the ACT with CF clinical trial that I mentioned a minute ago. This was also a several-year randomized trial at multiple centers, at this time of acceptance and commitment therapy, which is a therapy related to cognitive behavioral therapy. They included 124 adults with CF that had elevated depression and anxiety symptoms. So those could be higher than they were in the CF-CBT trial, which was designed as a prevention trial. And then they were either randomized to have the ACT with CF intervention or supportive psychotherapy which is therapy that kind of builds on your strengths and supports people to move forward with problems they may have. And then they saw how things were right afterwards and at 3 months. And they put together a measure of psychological functioning that included lots of different aspects. And they saw that the psychological functioning measure improved for both people who had the ACT with CF treatment and for people who had supportive psychotherapy, but it improved more for people who had the ACT with CF. And the components of that composite measure, the pieces of it that seemed to make the most difference was, one is a change in cognitive fusion, which means how likely are you to stick to thoughts that are unhelpful versus to be able to move on, and also a change in acceptance and committed action. So being able to understand this is the way things are, and yet I'm going to move forward towards my values and my goals. And both groups showed reductions in depression, but again, not so much in anxiety. Okay, next I'd like to talk about a study called WellMe, which is, and I'm going to present some data related to mental health in the WellMe study, but this is a part of a larger study that was co-designed by people with CF and CF researchers and clinicians, and the CF Foundation. Traci has been part of this study as well. So as part of this large survey study, there were 900 people who responded. Both adults with CF and parents of children with CF. And of those, 571 were currently taking Lexapro, tezacaftor, ivacaftor, or otherwise known as Trikafta or ETI, as Traci was calling it. And one of the questions we asked is, have you or your child experienced changes in the following areas since starting a modulator? And we asked about all different kinds of things, but these were a couple of summary questions. So you can see here that in the blue, that's people who thought things were better, and in the red or pink, people who thought things were worse. And overwhelmingly, people thought that their overall health and quality of life had improved since starting a modulator, and particularly here, Trikafta. But the story is a little different when we look at the mental health question. So again, in response to the same questions, have you experienced changes in the following areas since starting a modulator? Here we see for things like anxiety, agitation or irritability, ability to think clearly, like finding words or memory or concentration, depression, sleeping difficulties. People were just as likely, if not more likely, to say things have gotten worse than better after starting Trikafta. So why might that be? Well, it's actually really complicated. And this is one schematic of all the ways things might be interrelated. And so some of the reasons we might see those changes, one could be, and they may be different for different people, right? Or they're not mutually exclusive. People could have more than one kind of thing going on. One is that it can be a coincidence. It can be a reaction to the COVID pandemic, for example, or other things going on in people's lives. There could be a psychological impact of starting a modulator. So if you start it and it's not kind of doing what you hoped it would do, that can impact how you feel, of course. But even if you started and things are going well, even positive change is a stress, and that can change your roles and your feelings about yourself and your body image, all kinds of different things. So there can be a psychological impact. There can also be drug-drug interactions, so changes in levels of other medicines that might affect your mental health. But also we have some reason to think that there can be some direct impact on the brain, either through parts of that modulator binding to different neurotransmitters in the brain, or also changing the chloride balance in the brain, which also affects mental health. So there's a lot more to research to be done, but that's one of the things that PRIME is really focusing on, the Prioritizing Research in Mental Health Working Group. So to kind of further flesh out, one of the things on that chart is cognition or thinking. And this was a really interesting study that Dr. Lisa Scher highlighted in a symposium about ADHD and executive function. And this was a study by Helen Chadwick and colleagues from last year. So this is comparing people who don't have CF to people who have CF and don't have diabetes to people who have CF, who do have CF-related diabetes. And what this study found is that there were subtle changes in cognition or thinking. So verbal and spatial memory and cognitive flexibility, and about a 20% reduction in processing speed for people with CF versus people without CF. And then if you add CF related diabetes to it, then you see even a greater reduction in processing speed and executive function. So planning, organization, and things like that. So that can be another contributor. And Dr. Scher also highlighted a really wonderful post by Brianna Ragland about dealing with ADHD as a person with CF. And she talked about how it was really hard to stay on task, organize, remember things, time management. And that's hard when you've got to do regular therapies. So for her, it was really hard to create a structured routine. And it's almost as if she would forget that she had CF and then not do her treatments. So ADHD can have impact on people in general, but also there can be some CF specific impacts. So another really exciting symposium summarized the research on cannabis, and this is Sarah Fushi talked about summarized CBD in particular. And so cannabis or marijuana, there are various types, and so this kind of shows the lay of the land, but CBD usually doesn't have psychoactive effects, so doesn't change, how you feel. It's legal, right? And THC is the part that people use to change how they feel, and the part that is legal. It's legal in some states now, but still not federally legal. So this was focusing on CBD specifically. And one of the reasons it's important, people can use cannabis for lots of reasons. They can use it recreationally. Some people use it to see if it will help with sleep or anxiety or appetite or other things. But even though it's natural, it is a drug, right? And actually there are like 400 different chemicals that are found in cannabis plants. So CBD is known to increase the levels of other drugs. And that can be particularly important when someone's has had a transplant, and you could end up with levels that are too high and toxic, or if people have had bleeding problems and are taking or clotting problems and are taking warfarin for that. And it may impact Trikafta levels. And the other thing that could happen is because Trikafta can affect the liver, and also CBD was shown to affect the liver in some people during some studies, using those together could have an additive effect on the risk for a liver problem. So the upshot is it's really important to talk to your team if you are using cannabis, or you're thinking of using cannabis or CBD. It's important for people to know, because then they can help make sure that that's happening in a safe way. And this study was talking about how it asked people with CF, would they talk to their team about cannabis if they were using it? Were people aware of their use if they were using it? And for the most part, people were fairly comfortable talking about it, but we know that clinicians are not always comfortable asking. So this is some unpublished data that that Dr. Dagenet that should be coming out in a paper relatively soon, but she had presented this at the symposium. Okay, so I wanted to talk about as well another factor that can impact how you think and how you feel, which is sleep. There was a great workshop looking at studies that had been done about sleep for people with CF. And this one also related to people who started Trikafta. So at this CF center, what they did is looked at people who had studies of how their oxygen levels do at night before and after starting Trikafta. And so adding them all up, what you see here is before starting Trikafta, there were a lot of minutes, 800 something minutes, where people's oxygen was low, below 88%. And after starting Trikafta, there were only 38 minutes if you added them all up. So a huge difference in how well people were able to get oxygen at night. And so what they found is that of the people with advanced lung disease at their center who were using oxygen therapy at night, 2/3 of them were actually qualified to discontinue nocturnal oxygen, whereas a few didn't qualify. So that's just like Traci was talking about other treatments that, is it safe to stop them? Can they be stopped? Nocturnal oxygen is another one that could be it's easy to reassess and see if that's still needed or not. So thinking about people with advanced disease and lung transplant as well, there were several workshops and symposia focusing on that, and Joe Paluski highlighted some new guidelines related to lung transplant, models of lung transplant care. And he highlighted that although the median survival, like half of people with CF who have lung transplants survive more than 10 years, half survive below 10 years, but there can be a huge range from weeks to more than 30 years. The main reasons would be rejection of the lungs, infection, cancers, or kidney disease, but that we can be doing better, even better with this than we are now, and that there are some gaps in post-transplant care. So many of the people who are lost to follow-up in the registry were people after they got transplants. We weren't sure what was happening anymore. And it can really vary whether people stay in touch with their CF centers or don't after they have a lung transplant. And then there are even some times when people, because of the lack of coordinated care or education about all of the kinds of things people can do to stay healthy after transplant, sometimes people die from a complication that could have been prevented. So the models of care that Dr. Paluski highlighted, and it's kind of like, it doesn't matter which one you use as long as there is a model and someone's kind of running the show, right? So there can be a shared model where the transplant team is providing care for all of the transplant and lung related issues, but the CF program is still providing care for, everything else. I just went back here. And another model is that the CF team is no longer part of things after they refer for transplant and someone's transplanted, but the transplant program coordinates care and links in other subspecialists or primary care doctors as needed. Okay, so finally, this is a complicated chart. The reason why I'm showing it is to highlight how much exciting stuff is going on in the realm of health equity and cystic fibrosis right now. And this was a table that Gabriella Oates showed in one of the several health equity sessions that happened. And the upshot here is that there are lots of reasons that people can be at risk for health outcomes that aren't as good as they could be, right? So having financial problems, trouble accessing education or healthcare, problems in the neighborhood or environment, or social problems. And for all of these things, having CF creates some extra complications for some folks. And what that translates into is that there are policy strategies that we can use, again, both for people in the general population that are having disparities in various areas that can impact their health, but also specifically things for people with CF, like making sure that Social Security understands CF well, that there are programs for assisting people who have food insecurity or need specific help about financial planning when you have CF, or trouble with school because of CF. The particular impact of tobacco and secondhand smoke for people with CF, disability protections, and so on. And those are things that the CF Foundation is doing a lot of advocacy work in these areas, but there is much more to be done. So I will stop there.
Hello, doctor. Sorry, my camera's just taking a few seconds. It's excited about Boys to Men again. I just, so that we respect everyone's time, I just wanted to make sure that we dove into the Q&A. Can I have my helpers put an email for CFF in the chat? Just in case there's a question we are not able to get to. I want to make sure you have an opportunity and a contact you can reach out to so that you can get a question answered. There we go. Okay, so I'll dive into the live questions since we're here. So the first question is, will people with CF who start modulators, such as Trikafta, for example, when they're young, will they recover their fertility? So I'm going to throw that to Traci.
That's a great question. So I'm going to split this by sex and talk about females and then males. Males, it's a little more straightforward. So when you're a male with CF, you're born, 98% of males with CF are infertile, and it is due to a congenital absence of the vas deferens, which is a tube that really allows sperm to get out and fertilize an egg. So you don't have that tube. So you still make sperm, but you don't have the ability to have biologic children without assisted reproductive technology. So these new modulators, even the highly effective ones, can't rebuild that tube once it's gone. So no data that we know thus far, and no reports have come out of a male who has started a modulator and then recovered their ability to have biologic children without assisted reproductive technology. Females is a little more interesting. The anatomy in females is normal, but you do have thicker cervical mucus, and you may have alterations in the acidity levels that will allow sperm to kind of travel through and fertilize eggs. There have been lots of case reports, and certainly the baby boom, that has shown that modulators may improve female fertility by thinning out cervical mucus and restoring that normal pH level. So I think that it's the answer to that question is different from females to males. But I think there's still research that's being done in that area, and it's a really important question.
I agree. It's something I've been pursuing for a long time, but it's so cool to hear that, infertility is not just a blanket answer anymore, right? And just along the lines of that, Traci, what research is happening for women's sexual and reproductive health?
Yeah, absolutely. And I answered this a little in the chat, but I think that the short answer is lots. I think that there's ongoing research on how we deliver sexual and reproductive health care better in the CF care model, sex hormones and CF, and what that interplay really looks like. And Nicole, as you were saying, why you may feel worse on different periods of your menstrual cycle. I think we need to understand that better, including menopause. So big transitions in female sex hormones, I think, are important to understand. But there's a lot of work to do here. And I put some more of that in the chat back to the person who asked this question, and a lot of work that's being done. But these are the things that, when you interface with CF Community Voice, to really let your voice be heard about things that you would like research done on. And I think that that's really what us as researchers often are listening to prioritize what we need to study first.
Absolutely. Thank you. Anna, I'm going to throw you this other question. What do we know about memory and brain fog when on a modulator like Trikafta?
Yeah, so, as you saw in that, as I breezed through that graph, right, with all the different kind of mental health conditions that people were asked about, that's one of them, right? Thinking, memory, brain fog. And there have definitely been studies, single sender studies as well, that have shown that some people report those things after starting Trikafta. And, in many cases, the intervention might have been, for example, lowering the dose of the Trikafta. So it could be that the dose is too high for someone, or in some cases they stopped it and then started again and showed that there was a difference there. And I think, those are off-label treatments, so we don't know what that means, in other words, in terms of how safe is that going to be from a lung perspective for someone. So it's a really individual decision. So again, one thing you can do is talk to your team about does it make sense to switch anything there? The other thing you can do is to ask for a referral to see someone who has the ability to think about medicines that can help with that. Sometimes we find that stimulant medicines, for example, can help with that kind of brain fog and trouble thinking and trouble focusing that, even if it happens after starting Trikafta. So, and the other thing people can do is try to think of ways to kind of cope with it and combat it, and strategies that can be used, behavioral strategies. So there are lots of different approaches people can take.
There's so much being worked on, which is so encouraging. And I personally was diagnosed with ADHD as a 30-year-old with CF this year. So it's definitely something that I'm excited we're investing research money in. I feel like there's a lot more to come in terms of reproductive health and, mental health and things like that. So just for the sake of time, I want to respect our audience's time. It is technically our wrap time. So what I'm going to do is just give you a few plugs that we all wanted you to know for those who have to log off, and then we'll dive right back into other pre-submitted questions just in case anyone has a few more minutes to stay on and still party with us. So for a few plugs, I just wanted to take a moment to appreciate the depth of context that we had to report on today, right? This is definitely proof that we are getting closer to standing for cure found, right? I personally was diagnosed at age 5 in New Jersey, and that's not because I was unsymptomatic. I've been symptomatic since my birth, especially with nonsense mutations. And so to hear that this is no longer a terminal pediatric disease is so encouraging. Just as I said in the beginning, it's validating, it's therapeutic, and it's inspiring. So thank you not only for your research and for being brilliant, brilliant doctors that I'm thrilled to have on my team, but for compressing all of that information into a very short period of time. I really appreciate it. You making it so audience facing. I really liked the car stuff, and it's like good visuals I can keep in my head. So moving forward, there are just 2 plugs that I want you to have before some of you have to make on your way. Adapting CF Care Study. So this is a study that was sent through email through Community Voice. And it's an opportunity for people with CF, their families, their care teams, really anyone in our community to share their thoughts on how your CF care center can provide you with more modern care. So we as a community need a lot of things that we didn't necessarily need in the past, or vice versa. As we're aging, right, age 53, age 56 being the average, we're going to have needs as parents instead of just as pediatrics. So please, please, please do that survey. It's only open through December 20th. So do it right after this call if you can. I did it. It took me about 6 minutes, right? And the second plug is for yours truly. My 6th book is coming out on Friday on Amazon. It's called My Washer Dryer. And it's basically a metaphor about how laundry can explain the thoughts and processes of pre-lung transplant. So if that's something you're interested in, you can find that on my social media. So in terms of this recording, this will be up on YouTube. And if you registered, if you're watching this live, you will also see in your email a link that will take you to the recording of this video. So you'll see that in the future. But moving backwards into questions again, I want to dive into 2 more live questions that we got. So this one is, are there any research on discontinuing chest PT or vest therapy once you go on modulators?
Yeah, that's a great question. I threw a quick answer. I think this is an important question that's top of mind, not just for people with CF, but also for us as providers, because I think anecdotally, a lot of people that I care for have kind of slacked off or backed off on their own with their airway clearance in that way. It has not been formally studied yet, and I don't think that there's anything imminently that's coming down the pipeline to look at that. But I think that, the Simplify study where they looked at taking away hypertonic saline, taking away dornase alpha, was really that first study for us to start thinking about peeling back some of these things. And I do think that airway clearance is such a crucial bit of how you care for CF with regards to breaking up that mucus and getting it up and out, that I think that it's definitely on the list. And I know that it's of high priority for people with CF. And I know that researchers are hearing that message. And I think it's just a matter of how do we fit that into when we study it, and in what way is the safest way to do so. But that's a great question.
Absolutely, especially as someone who didn't necessarily benefit as much from the vest and had to do good old chest PT, right? Turn Downlenberg and all that. My mom would appreciate to hear that she doesn't have to clap me for 30 minutes 3 times a day, but she's a strong lady. I give you that. Okay, Anna, I'm going to throw this one your way. Have there been studies looking at anti-anxiety medications such as Lexapro and their possible interactions with modulators?
So there have not been studies. However, if we go back to the Orkambi days, we know that Lumacaftor, which is one of the ingredients in Orkambi, that was on the labeling for the product that Lumacaftor could lower the levels of medicines like Lexapro. So some of the SSRI serotonin-based antidepressants, but not others. And it's really based on the way that those medicines leave your body through the liver, whether they take this door or that door. So it's not really the type of medicine, it's just the specific medicine and how it chooses to leave your body, and whether that means it's going to raise the level or lower the level. Now, that particular interaction doesn't apply to Trikafta, because Lumacaftor isn't an ingredient in Trikafta. However, there are other kinds of pathways. There are like P-glycoprotein and all this other stuff. And so there is a possibility with Lexapro that that it could, Trikafta could elevate that level, but no one's looked at that to see if that's actually the case. The other thing, again, anecdotally, might be that because we think there may be some impact on serotonin from some of the ingredients and modulators, I've seen some situations where it looked like there was kind of too much serotonin there. So again, if somebody is starting, starting a modulator who's already taking an antidepressant, and things are not going well, one thought is it reducing the antidepressant that might be helpful in that situation, depending on the way in which it's not going well. So again, there are lots of different interventions that might be appropriate for an individual person based on what they're experiencing, what their history has been, and then how things go as those alterations are made.
Yeah, thank you for that. It's something I personally have to be aware of as someone on a reduced dose of Trikafta and on anti-rejection medication. Sometimes they can affect, but I think it's just kind of a case-by-case scenario, right? All right, we have a few pre-submitted questions here. The first is from Genetic Therapies. So is the editing of CF genes for a cure looking at using the CRISPR technology used to treat sickle cell disease? That is cool. During the presentation, we talked about like how sickle cell and treatments for that could apply to CF.
Yeah, I can take that one. So CRISPR technology is definitely one of the many gene editing tools that CF researchers are exploring. It's been used to edit CF mutations in cells in the lab thus far. I think one big challenge to gene editing in CF is how do we deliver those therapies to cells in the lungs, because they can be really difficult to reach. And I think that's the key difference between CF and other diseases like sickle cell. And I know that researchers are really looking at this and working to develop these vectors, which are specialized delivery vehicles, to really package up these genetic therapies and then deliver them to the right cells that need to receive them in the lungs. So that's a great question.
Yeah, that is a good question. Thank you for answering that. Next is modulators. We do have many people interested in modulators. So one is, are there any intentions of developing a modulator for infants or newborns? So younger than what's on the market now.
Yes, I think that is historically been kind of how the drug companies have been testing these modulator therapies, that they start marching down. So currently right now for ETI, people are eligible if they're age 2 or older with one copy of Delta F508 or one of the other handful of mutations that are eligible for these drugs. And I think that they've gone down in ivacaftor and some of the other modulators to as young as 1 year, 6 months. And I think that that's really going to be the trend that we're going to see. So I think this is one of those things that is another, stay tuned and we'll see how time will tell.
Absolutely. Let's see what else we've got here. How about for CF patients who do not have a Delta 5 F08 mutation? Is there anything else in the works for them?
Absolutely. And I think one thing which was exciting from NACFC that I highlighted in the talk was from Dr. Solomon's talk on the N1303K. Sorry, I had to remember it, which is not a Delta F mutation, obviously. And it's really testing to see if ETI works for those patients. Now, there is a PDF that we can throw the link to in the chat that's in English and Spanish on the CFF website that has approved mutations for modulators. So we'll put that into the chat now so people can see that. And I think that this is a conversation that I have with my patients who are not eligible for modulators. I, as a provider, am checking this pretty routinely to see if anything's been added, to see if any new research has been out there. But it's definitely something that I encourage you to advocate for with your CF team and say, is there any new research on modulators on my mutations or any therapies that I may qualify for? And I think that lots of people have asked me that question, and I think it's a good one to keep checking in on because research moves quickly.
It does, especially with everything y'all have presented today. How many things are in the works? You've got a lot of irons in the fire. We have another live question here. So how would you be able to assess potential mental health challenges in infants and young children if they were to take any of these medications?
Well, believe it or not, there actually are some validated measures of behavior and mood and kind of mental health functioning in infants and toddlers out there. So one thing that that some centers are doing is to give some of these measures before the child starts the new medication and then give the measure afterwards and look at the comparison. And of course, you're also going to be asking, the parents and caregivers what they're noticing, and the CF care team, hopefully knows these kids well, even though they're young, and can kind of say, something's different here, right? But we can be kind of in touch more frequently than we normally would be in using some of these standardized measures to track.
Absolutely. And that's cool to know too, because I've always felt a bit like I'm talking to myself. In my youth, I would tell my doctor I'm having some mental health concerns, like this medicine is giving me anxiety, but my lungs would always take priority. So it's good to know that there are ways to assess it where I'm not feeling like a crazy person. There's some validity to it. I appreciate that. Another live question. Let's see. As people need increased specialists and general med care who have CF, is there any talk about building a bigger network of interdisciplinary teams? Do we know if we're going to be adding roles?
I think that's a great question. And I think that I can talk about this, from my narrow research focus around sexual and reproductive health. I think we recognize that it is helpful as people with CF have told me that when they go to a sexual and reproductive health provider, sometimes it feels like they're teaching that person about CF, and that person has no concept of what modern CF looks like. So I think, increasingly we want to make sure that we're spreading the message as CF providers and care teams to our colleagues that historically we may not have been interfacing with as much. And I think that includes sexual and reproductive health providers, fertility specialists, gynecologists generally, but also primary care providers. And I think that, what we've really seen in several surveys now that were connected to sexual and reproductive health, but this was a general question, is that a not small amount of adults with CF don't have a PCP that they routinely see. And I think that we as CF providers really need to think about how we're going to interface with PCPs in addition to these other subspecialists. So I think that's a really great point. And I think that Anna put in the chat, back that I think that this is one of those key points that really would be helpful to that Adapting CF Care survey, right? We really want to understand what your thoughts and priorities are when we think about what CF care looks like in 5 years, in 10 years, in 20 years. So we can be forward thinking and build the supports and structure that we really need and that you really want.
Well, I'm looking forward to having all of the irons in one contained place. As a patient myself, it's a full-time job ensuring that all of my care team providers are communicating with each other so that nothing's overlapping, everyone's on the same page. So I'm looking forward to it being a more cohesive unit. From my end, though, I'm blown away by the amount of research and progress that we've made. I thank you two so much for all of your presentations. Is there anything else you would like to say before we wrap?
Thank you for your patience, because even after a pandemic, I can't manage Zoom, I guess. So
You've got a lot going on.
I thought I had it. I thought I was good, but nope, still not there. But I really thank you guys for staying on. I know that lots of people are still on and people will be listening at home. So please don't hesitate to reach out to the CF Foundation with questions and certainly check out those YouTube links, because I think that there's so much cool stuff that's going on. That's right. Dr. G, how about you?
Yeah, I'd just like to thank everybody for their participation, all their great questions, and in particular for participation in research, right? Because if no one participates in research, we can't answer any of these questions and bring that, that improved care back to people with CF. So thanks so much for coming tonight.
That's right. So thank you to our audience for listening, to watching us gab about all of the latest statistics and trying to compress it at least a little bit for you. All of those YouTube links are live. They are available in the chat if you weren't able to keep up. If there was a question that was not answered, please reach out to research@cff.org. Otherwise, thank you so much for your time. Make sure you do that survey, community voice. Look for it in your email, and we will see you soon. Have a great night, everyone, and thank you.